Thank you so much for joining our Psychiatry Grand Rounds today. We're very excited to have Dr. Liz Lawrence, who I'm very fortunate to have worked with in the Department of Wellbeing, in the Office of Professional Wellbeing, and I think many of you know from her role there. So she is here to present to us today on imposter syndrome and in light of the discussions on well-being in medicine. So let me go ahead and introduce Dr. Lawrence. Dr. Liz Lawrence is a graduate of Yale College and Stanford University School of Medicine. She has lived and worked in New Mexico since 1995 when she moved here to begin her 3-year internal medicine residency. And she currently practices general internal medicine at UNMH's Northeast Heights Clinic. Dr. Lawrence became a general internist because she cherishes the long-term relationships built with patients from age 16 to 103. Her area of academic interest has been on clinician well-being since 2013. At that time, while in private practice caring for many physician patients, she became disheartened to see the toll of clinical work on doctors. She believes that the need to change the culture of medicine to one in which clinicians can thrive and experience joy in their practice. She believes this change will come about only when we build a healthcare system that puts primary emphasis on patient welfare and not on productivity and paperwork. Dr. Lawrence has spoken on professional well-being throughout the country and has published in this field. She was UNM School of Medicine's first Chief Wellness Officer and Dean for Professional Wellbeing. She is currently the Senior Vice Chair for Faculty Development in the Department of Internal Medicine. And again, thank you so much, Dr. Lawrence, for being here with us today. I'll hand it over to you.
Thank you for inviting me, and it's a pleasure to see some familiar faces and to see you, and I appreciate this opportunity. I'm going to go ahead and share my screen. I am presenting from the Northeast Heights Clinic, so you may see some background movement, but I am here. I won't be able to see the screen when I am in the share screen mode. So if someone could keep an eye on the chat, I don't know, Dr. Sauer, if you're able to keep an eye on the chat, and feel free to interrupt if something is pressing. Otherwise, we will have time for questions and answers at the end. And you should be seeing my slide, is that correct?
Yes. Yes.
Okay, thank you. So I'll be talking about imperfection and perfection and perfectionism in medicine and what that means and how it impacts us today. There are a couple of areas of controversy that I'll be presenting, and I do so with humility and look forward to lively discussion when I am done presenting. Please feel free to raise any concerns or thoughts that you have. I don't have any disclosures, nor do I seem to be able to advance my slides. Okay, I don't have any disclosures. Our objectives for today are to really come away with a good understanding of what imposter phenomenon is and what maladaptive perfectionism is and the overlap between the two. And we're going to compare those to healthy striving for excellence. We all want to be excellent in what we do, but that's not the same thing as trying to be perfect or maladaptive perfectionism. We're going to discuss some of the positive and negative professional consequences of these phenomena, and then we'll spend hopefully half, maybe only a third of our talk talking about individual and system-wide strategies that can be used with ourselves, with our learners, with advocacy at the institution. I want to start off by sharing a story of a young woman who matriculated in medical school. And this is someone who can't believe she's been admitted to the class of 1995. She's an atypical student, at least 6 years older than most of her classmates, married, and a humanities major. She did well in college, but certainly did not have straight A's. Her MCATs were strong, and she knew that she had interviewed well in the medical school application process. She spent her preclinical years, her first couple of years of medical school, overstudying and anxious because she was so afraid that others would realize that she was never meant to have received an acceptance letter. She does well in medical school in spite of coming home after every exam and telling her husband that she failed, or coming home after rounds and telling her husband that her attending hates her. She matches at her first choice residency program and continues to thrive. The more accolades she receives, however, the more fraudulent she feels, and the more likely she believes she will be found out. Her only strategy to overcome this feeling that she is faking it is to work as hard as she possibly can, forgoing sleep, forgoing self-care, exercise, and time with loved ones. She never feels like she quite belongs, as she is still older than most of her fellow residents and is initially the only parent in her residency class. She never has a chance to hang out with her peers because she's either taking care of her child or trying to find some time to spend with her spouse. After residency, she joins the faculty, and after a period of about 7 years, leaves for private practice. She continues to thrive, but every time she receives a compliment, she says, "Oh, I just do what anybody can do." She continues to feel she needs to work harder than everyone so that people will accept her. And roughly 20 years after starting residency, this physician is burned out and ready to leave practice. We're going to come back to this case. Some of you may have felt some familiar themes as I was talking about this woman, and we'll come back to it at the end of our talk. Imposter phenomenon is a phenomenon term, and most of you will know the information on this slide. I'll just review it quickly. It's a term that was coined by two psychologists who were at Oberlin College, Clance and Imes. One was on faculty, one was a senior grad student, I believe. And it refers to high achievers who are unable to internalize and accept their success in spite of a lot of data from the outside telling them that they are successful. It's also an internal belief that the affected person's success comes not from ability, but rather from luck or beneficially inaccurate evaluation. With this phenomenon, positive feedback and success are often externalized, while negative feedback is internalized. I want to point out that we often use the term imposter syndrome, but that's not really accurate. What Clance and Imes had in mind was a phenomenon, and they deliberately chose that word because they did not want to pathologize the construct or the experience, and they were really using it to depict a particular internal experience, not to diagnose someone with something. So I'll be using the term imposter phenomenon or IP on my slides, although you'll see sometimes I'll slip and say imposter syndrome.
Yeah, because it's a Medicare.
If you feel like you're hearing a lot about imposter phenomenon in recent years, you're right. There is very little in the literature till about 2022, and then we see a sudden spike. And here we are in 2023, 2024, seeing just an outpouring of information.
No, we changed it to a compound.
Even as you're hearing more about imposter phenomenon, we're also hearing more controversy about this phenomenon, and I want to spend a few minutes talking about that. One of the critiques, or the most common critique you'll hear, is that Clance and Imes did their study in high-achieving white women. This all started because Clance and Imes, I just read there's a good article in the New Yorker recently which covers this, and I'm happy to provide that reference. But they had some kind of party to welcome other graduate students, to welcome undergraduates taking psychology courses, and they just started talking about, the feelings of not belonging, and it resonated with everyone in the group. And that's how they felt they were onto something. But it was a group of all white, privileged, high-achieving women. And one of the controversies that has come up, and I'll show you the citation in a minute in which this came up, it was a Harvard Business Review article, was that, maybe it's not so much that an individual is experiencing imposter phenomenon, but that it's a result of systemic racism and bias, and that people who should feel confident in their abilities are finding themselves in situations where their competence or their intelligence has been underestimated, and that they feel like they don't belong because there's a lot of signals telling them that they don't belong. There may be no one else in the room who looks like them. There may be no portraits on the walls that look like them. There may be no peers that look like them. And it's a sense that perhaps many people who typically have been underrepresented in medicine, women, but women in color more, and others who have been underrepresented, may just feel that the environment isn't appropriate for them. And this is the Harvard Business Review article. I really encourage you to take a look at this. It was really eye-opening for me to read this. And the author talks about how for women of color, self-doubt and the feeling that we don't belong in corporate workplaces can be even more pronounced. Not because of women of color, which in and of itself is a broad, poorly precise categorization, not because they have an innate deficiency, but because of the intersection of race and gender often places such women in a precarious position at work. Many of us, and it's the author who's using the us, many of us across the world are implicitly, if not explicitly, told we don't belong in white and male-dominated workplaces. Half of the women of color surveyed by Working Mother Media plan to leave their jobs in the next 2 years, citing feelings of marginalization or disillusionment, which is consistent with the author's experience. Exclusion that exacerbated self-doubt was a key reason for transitions from corporate workplaces to entrepreneurship. So maybe one reason certain groups have experienced the imposter phenomena is because they haven't been welcome at the institutions in which they are trying to work. And the article goes on to talk about how when we talk about imposter phenomenon, we're talking about an individual. What can I do so that I don't feel like such an imposter? It puts the blame on me. You know, if you felt more confident, if you had a different way of framing issues, you would not feel like such an imposter, as opposed to putting the issue on the institution and asking for change of the institution. Now, you may look at this and say, well, certainly there are white men that feel imposter syndrome, and they do, or imposter phenomenon, I should say, and they certainly do, but not to the extent that people typically underrepresented in a certain space do. And we'll look at some of those studies in a little bit. But I want you to really think about, is imposter phenomenon the right construct? Or are we really talking about something at the systems level that needs to change? Taking a step back from that controversy, I want to point out that in the original study, there were 5 types of imposters identified. And I found this categorization really helpful for working with learners. I'll be curious if you've used it. But the idea is that there are different types, and there are people who think they're a natural genius or should be a natural genius, because with all of these types, there's an impossible standard. And a natural genius finds failure when encountering difficulty despite success. They feel that they should know everything. They feel they should be able to do everything, figure everything out. The expert feels like they should know everything perfectly. And the superhumans require themselves to juggle multiple tasks and multiple jobs simultaneously. The soloist feels that she's a failure if she has to ask for help. And the perfectionist, really, which can encompass some of these types or all of these types, has such unrealistic expectations of success that no matter what they do, they never feel like they belong or that they've been successful or made the mark. And educators can use these subtypes to understand and identify and reframe unrealistic self-expectations the learner may be internalizing, and reinforce that imperfection does not disqualify intrinsic ability. You know, not knowing something doesn't mean you're not an expert in other things. Having to ask for help doesn't mean that you're a failure. And having this vocabulary, I have found very helpful for helping students who often have unrealistic standards and a failure to accept their own best efforts. So we've been talking about imposter phenomenon. How does that relate to maladaptive perfectionism? And what is maladaptive perfectionism? It's characterized very much the same way these 5 types of imposter phenomenon are characterized, by unrealistic standards, self-criticism, and a failure to accept, and I just used this phrase on the last slide, one's own best efforts. Self-worth is often determined by externalized feedback and how others perceive you, and it depends on striving, achievement, and accomplishing, being awarded and recognized for that, not a sense of, oh, I did my best or I tried my hardest. Avoidance of negative judgment is a strong motivator, and that's important because it really feels different to do something because you want to do it as opposed to doing something because you don't want others to judge you negatively or because you don't want to be perceived as a failure. And I think a lot of times with our learners, sometimes with our colleagues too, we see this phenomenon where students want to be perceived as bright and professional and caring. And so they go beyond what might be their comfort level because of that fear of failure or being perceived negatively. It's certainly associated with having a fixed mindset. If I don't do well on this math test, it's because I can't do math, as opposed to, maybe I need to rethink my study methods, which would be a growth mindset. And it's different than striving for excellence. And this is really the difference between maladaptive perfectionism and striving for excellence, because it results in negative consequences such as anxiety, depression, and burnout, because it ignores the self needs, it ignores what you as an individual might need in order to achieve a goal or avoid failure or achievement. And it's that ignoring of self where it crosses into something that is maladaptive. What is the overlap between imposter phenomenon and maladaptive perfectionism? There's certainly a lot of overlap. Again, extremely high unrealistic goals, tending to discount positive feedback, criticizing oneself if the performance is less than perfect or doesn't receive the accolades one is expecting, depending on others for validation, overgeneralizing the negative effects of failure. I didn't do well with this patient, so I guess I'll never belong in medicine or never be able to succeed. Again, motivated by that fear of failure and constant comparison of self to others. And so I guess I want to throw out whether, since there's so much overlap between imposter phenomenon and maladaptive perfectionism, is imposter phenomenon really its own phenomenon? Is it the right term? Or is what we're talking about a combination of maladaptive perfectionism and institutions that have not quite adapted to having such a diverse workforce or diverse student population as we are seeing now? I don't have the answer. It's a controversy that remains in the literature, and one I'd love to hear your thoughts on at the end of this presentation. But it does strike me that when institutions are as unwelcoming as some institutions can be, of course someone doesn't feel like they belong, particularly if they have all these traits of a maladaptive perfectionist. I happen to be reading a book right now. I'm not quite sure how I landed on it, but it's called Sisterhood, and it is about the first women in the CIA. And these are bright, talented, hardworking women who really wanted to serve their country and who were made to feel so unwelcome in the early years of the CIA that, of course, they felt like they didn't belong. And I was just listening to the book as I was on my commute today and thinking about this talk and really thinking, there can be so much institutional culture which is unspoken, that is unwelcoming to those who haven't traditionally been members of that culture. So are we using the right terms? So what are some of the risk factors for imposter phenomenon? If we do use that term, it's really all the same risk factors that are there for a maladaptive perfectionist. Someone who is high achieving, driven to succeed, has been inculcated with high expectations from parents, from school, from colleagues, Often it's someone who has strengths other than just intelligence or knowledge. They can be charming or convincing or a good listener. And so you'll often hear students say, or I've certainly been guilty of saying this, oh, I'm not that good at it. It's just that I smiled nicely or I was polite, so people like me. They're giving me a pass. That's something that we hear with imposter phenomena. And this is a really key one for our students and can really affect how we work with learners. Is most people who experience the maladaptive perfectionism or the imposter phenomenon don't have a lot of experiences with failure. And helping them kind of push the boundaries, helping ourselves push the boundaries so that we're in situations where we might fail and see that we do okay. The more experiences we have with failure, of course, no one wants to keep failing all the time, but the more we recognize that failure is a natural part of our professional progression, it can be really helpful in relieving some of these symptoms. Some of the triggers for imposter syndrome, and now we start to get to the environment, are really finding yourselves in a new environment with new expectations and new people around you with new responsibilities, so that you feel out of place. And again, one of the triggers is failures or mistakes. What are some of the system or cultural factors that lead to imposter phenomenon? Well, I want to emphasize this because I think this is one place where we can make a change, at least at our own institution, and where we are starting to change. And one system factor is the way that we select medical students. There's an article, gosh, I don't have the reference in my notes here, from 2018, I think, that where students, the author does a study of students who were admitted to medical schools across the country. And he notes students seeking entry into medical school must now possess almost perfect records of academic and extracurricular achievement. The mean undergraduate grade point average of the medical school matriculants in 2016 was 3.7, and the mean MCAT score was at the 80th percentile of test takers. So if the mean's at the 80th percentile, that doesn't leave anyone a lot of room to be average. In high school and in college, many of these students put enormous pressure on themselves to excel academically. And it is reasonable to hypothesize that this academic path could encourage development of dysfunctional patterns of thinking, including maladaptive perfectionism, imposterism, and equating academic performance with identity and self-worth. In medical school, where half of each class is, by definition, below average, such patterns of thinking may become more acute and could have a negative impact on student mental health. And I frankly, having worked in the wellness office for 6 years and talked to many students, I really do believe that many students, many of our residents and fellows, and many of our faculty experience this. So how we select students may be that we're selecting for maladaptive perfectionism or encouraging the development of that trait. Other system factors that we've already talked about is not having anyone in the room who looks like you, not having role models, a lack of psychological safety, which is often our medical culture, where you don't feel safe acknowledging you don't know something, and so you may try something that feels very uncomfortable. Policies and procedures that are not inclusive, and for this I'll cite still our child care policies about who, how much time one can take off to be with one's kids, flexible schedules that would enable some of our colleagues or learners to pick their kids up at daycare or drop them off. And also being called on to represent a whole population of people. I'm Jewish, and with the recent events in the Middle East, sometimes people say, well, what do you think, or what do Jews think about what's going on? Well, obviously, I can't speak for a whole population, and that contributes to my feeling like an imposter if I try to. So really, again, I'm not sure there's much of a difference between imposterism and maladaptive perfectionism, or whether they're talking about the same phenomenon coupled with what's going on in our institutions. Certainly, there's a very common cycle that we see where a learner or a colleague or for ourselves. We set an unrealistic goal. We don't achieve that goal. And so we engage in cognitive distortions about, well, I don't belong here. I'm never going to be successful. Oh, I didn't do well at this, so I won't do well at that, which leads to the imposter syndrome, which leads me to say, oh, I better prove myself. I want to make sure all my colleagues know I belong. I'm going to set this goal. It's not that I consciously think I'm going to set an unrealistic goal, but I set a goal which really requires superhuman strength. And then I don't achieve it, and the cycle perpetuates itself. How common is imposterism or maladaptive perfectionism in our profession? There was just a study released this year by the group at Stanford that does so much work into professional well-being. And they were using data collected between November of 2020 and February of 2021 when they surveyed US physicians and a probability-based sample of the US working population. They used a 4-item version of Clance's original imposter phenomenon scale, which is, I believe, normally a 20 question scale. They just used 4 questions. I'll show them on the next slide. Burnout and professional fulfillment were studied using standard instruments that they've used in many studies, we've used in studies. And they compared the over 3,000 physician responders to the population-based sample. And surprise, surprise, between 4 and 10% of the physicians surveyed endorsed each of the 4 imposter phenomenon items is a very true characterization of their experience. Physicians have a greater intensity of imposterism than the general population. And imposter phenomenon was associated with burnout, suicidal ideation, and lower professional fulfillment. That shouldn't be surprising if you're setting unrealistic goals repeatedly for yourself, foregoing sleep, foregoing self-care in order to achieve these unrealistic goals. Burnout, depression, suicidal ideation, a lack of professional fulfillment because you don't feel recognized for your efforts would be expected consequences. And the authors conclude, again, that systemic efforts are needed to address professional norms and perfectionistic attitudes that contribute to this phenomenon. And so again, looking at our admissions policy, and are we encouraging people with the right traits to apply and be accepted in medical school? The questions that were used, the 4 questions from the Clance 20-item scale that were used in this study are right here. When people praise me for something I've accomplished, I'm afraid I won't live up to their expectations in the future. So someone says to me, well, that was a great diagnosis you made, Liz. You must be a really great diagnostician. And then I live in terror that I'm going to miss the next diagnosis and they're going to find out. I'm afraid people important to me may find out that I'm not as capable as they think I am. I'm disappointed in my present accomplishments and feel I should have accomplished more. And I often compare my ability to those around me and find that others are more intelligent than I am. And you can see that quite a large number of physicians experienced all of these phenomenon and were much more, and you have these numbers over on this side. If anyone feels comfortable putting in the chat whether any of these questions resonate with them, please feel free to do so, or again, we can discuss this a little bit later. What about our learners? There was a really great scoping review, the reference is here, looking at medical students and residents. Residents came in about 1/3 to 40% in all specialties having imposter syndrome or imposter phenomenon, excuse me. The medical student studies were sort of all over the place, anywhere from 20 to 60% of medical students were found to have imposter phenomenon. That may have been dependent on what year they were surveyed, whether they were preclinical or clinical, but certainly a high prevalence. If we're estimating that this is as high as 10% in practicing physicians and even 20% in our students and 30% in our residents, that's affecting a lot of us. And in this scoping review, they found again that perfectionism was associated with an increased risk for imposter phenomenon. Are they the same thing? Are they overlapping? Again, the association with burnout. And again, that this affected females more than males. I should say in the 2023 study I just cited by the folks at Stanford, imposter syndrome or phenomenon was also higher in women, higher in younger women, there was variation by specialty, and those in academic medicine had higher rates. I gave this talk for our pediatric colleagues a month or two ago, and interestingly enough, the highest rates of imposter phenomenon in physicians were seen in general pediatricians and specialty pediatricians, but even more so general pediatrics. We did a study here several years ago of our UNM students. I helped mentor these students, although I was not the PI or involved in this study. Martha Gallegos and Deanna Gonzalez, both of whom have gone on to residencies here. They had a total of 163 total responses. And of those people who responded, about half scored positive for the imposter syndrome. They did not use the Clance and Imes scale. They used the Young scale, which is a little bit different, but also has been validated in the literature. Saw a much greater incidence of imposterism in women than male students, and a significantly greater increase in our underrepresented in medicine students, as you see here. Dr. Young's scale, just to provide a little background, is an 8-question questionnaire for imposter syndrome, and students who scored greater than or equal to 5 questions were considered positive. Students were invited to take part in this survey via a link sent to their Salute accounts, and any students who were actively enrolled between 2014 and 2018 were available to participate. So I think this is really striking, and I do think, just as we talk about with physician well-being, when you have something that's affecting over half or almost half of a population of people, then you have to think, what's going on in the system that is contributing to what we're seeing. So if imposter phenomenon and maladaptive perfectionism, and again, those terms are hard to tease apart in my mind, are so common, there's got to be some benefit to it, right? Why do they keep going? Why does this phenomenon keep going? And in part because we do want our physicians and clinicians to have very high standards, and so we're selecting for that. It does motivate people to work hard, right? They set higher standards for themselves. They want to get higher scores on exams. They want to do better diagnosing, better physical exams, better consults, be a better colleague. So in the one hand, it does encourage hard work and perhaps even better skills, and maybe makes us more conscientious and less likely to make mistakes. It keeps us humble and prevents bragging. So there are some benefits to these phenomena, which may be why they're so hard to extinguish. But as you can tell, comparing this slide to the previous one, there are a lot more costs than benefits. And I want to highlight a couple of the behaviors or consequences that are listed here. One is that sometimes when someone really is so scared of failing, or really just wants to do so perfectly, or cares so much about what you think of them, they can become paralyzed. They can't make decisions or take action. Maybe they don't apply for a certain fellowship because they don't want to be rejected, or a certain grant because they don't want to be rejected, or a certain job. And it can lead to people holding back from sharing their ideas. They don't want to be criticized or made to feel unwelcome, or just feel like they don't belong even further. So they may not step up to challenging opportunities. And at the personal level, of course, this is what leads to the increase in burnout, suicidal ideation, and lack of professional fulfillment that we saw in the studies that I just cited. It also leads to increased difficulty asking for help, and anyone who has practiced medicine for a long time knows we need to ask for help. In fact, I presented a case at the clinician meeting today in my clinic where I was asking for help because I really didn't know how to handle a patient that I perceived as difficult. It also can lead to a lot of rumination. And finally, just a lot of wasted time in terms of overwork and over preparing. I was talking to someone who spent tens and tens of hours working on preparing a grand rounds, and the grand rounds was terrific. It was fabulous. But how much of that work was driven by a need for him to achieve such a high standard as opposed to being more relaxed about the presentation and accepting, well, you know, I do need to get some sleep. Maybe this is good enough where I am. So some benefits to maladaptive perfectionism and imposter phenomenon, but a lot of cost. And at the organizational level, I mentioned some of those with the previous slide, but mostly focused on individual consequences. At the organization level, we're ending up with a less diverse workforce or student body than we might like, with fewer ideas and solutions, and therefore lost opportunities, a smaller talent pool. We see higher dropout rates for women and underrepresented medicine faculty members, and that's why, you know, we have over half of our students for the past few years have been female in our medical school classes, and that drops off a little in residency, still about half and half. But by the time you get to the chair or dean level, many, many fewer women. And that's because we're losing people in the pipeline. Same with people of color, people who have been traditionally underrepresented. How can we keep those folks in the pipeline? And I think addressing some of these issues at the systems level is the way to do that. Procrastination, again, you know, oh, I'm not going to apply for that job. I'm not going to file that application because I'm not going to succeed, leads to needless stress and wasted time and avoidable crises, which can impact team members. And again, the overworking and over preparing. So I imagine that all of you in psychiatry are familiar with the Kruger and Dunning effect, or the Dunning and Kruger effect, which is a cognitive bias where people of low ability mistakenly assess their ability as high. You know, let's say I am lousy at math, but I keep thinking, I'm really good at math. I'm doing pretty well. And that's where the Dunning-Kruger effect is. You know, in many ways, we can think of the imposter phenomenon or maladaptive perfectionism as a seemingly similar cognitive bias, except that we're at the other end of the scale here, where our actual ability is high, but we perceive it as low. And I think this is a really important way to frame imposter. Oh, I have imposter syndrome there, not imposter phenomenon. I think this is an important way to frame imposter phenomenon, because we know that cognitive biases such as overgeneralization or magnification or catastrophizing respond well to cognitive behavioral therapy. And maybe for some of our learners or colleagues with imposter phenomenon, rather than just saying, oh, you're really great, I'm sorry you feel that way, but you're doing a terrific job, and hoping they kind of snap out of it, we really need to refer them for some cognitive reframing and cognitive behavioral therapy to help them address this issue, because we have seen there are negative consequences for the institution and the individual. So what are some strategies that we can do at the individual level? Certainly acknowledging that imposter phenomenon exists and remembering how common these feelings are. I think one thing I often hear from students is, you know, the belief that I'm the only one that feels this way, when in fact, we just saw anywhere from 20 to 60% of the class in the national literature, or up to 80% of certain populations at our own institution can feel this way. Confiding in those who are trusted mentors or role models or peers can often give you some feedback that can be validating or help you reframe. Again, working on cognitive distortions, because that's what this is. And remembering what successes and what skills you do have. keeping a list of positive accomplishments that is easily accessible at times of self-doubt. Sometimes students have been advised to put up Post-its around the room of what they've succeeded at. And the asking to be on recruitment committees, that feels sort of a little out of, if I were to ask which one of these is not like the others, that one feels a little different on this slide. But helping to see who the candidates are who are competing for a place that you already have can be very validating, and also having a say in who else is coming on as a new student, a new resident, a new faculty member who looks like you can be very helpful. So participating in the recruitment process can be one strategy for an individual to improve. I don't know how many of you are familiar with the 12 Tips series in Medical Teacher. It's a great series, 12 tips for discussing well-being, 12 tips for giving feedback, 12 tips for reflection. And the series goes back many years, but this was a recent paper. I think it was a 2023 publication. It was. And it's 12 tips for recognizing and supporting medical learners who are experiencing imposterism. And I pulled out the 12 tips, or most of them here. And it's really what we talked about, but also recognizing what triggers there are. We saw that being in a new environment with new expectations and new colleagues can be a trigger. So what about our learners who are on a new clerkship every 6 weeks? Of course they're going to experience, if they're prone to it, imposter phenomenon. So what can we do to clarify expectations, to make that transition smoother? We can screen for burnout, for depression, for other consequences of imposter phenomenon or maladaptive perfectionism. Setting consistent, appropriate expectations, role modeling your own expectations for yourself. So, sometimes just an attending saying to a student or a resident, hey, I'm not going to be able to be at that meeting at 2:00 this afternoon because I'm watching my kids play soccer, or because I'm getting my colonoscopy, or I'm going to the dentist, can be a really powerful message that it's okay not to attend everything. It's okay to be human. Promoting growth mindset, encouraging support, nothing surprising here, but it is a nice summary article. At the group level, what can be done to address imposter phenomenon and maladaptive perfectionism? Certainly talking to your coworkers, having talks like this, recognizing when others are confiding their vulnerability to you and respecting that, helping them remember their worth, supporting your peers in winning awards and recognitions, making sure there are awards in your division, in your department, that acknowledge our youngest colleagues, our up-and-coming colleagues, our newest colleagues, and helping each other celebrate. I'm going to share a quotation on the next slide, which I think is really powerful. And again, this gets to the idea about what can we do on the institutional level, because aren't we really dealing with an institutional issue? Imposter syndrome is but a symptom. Inequity is the disease. Promoting equitable representation of women and minorities among the leaders of medicine through concerted systems-level intervention is the most appropriate treatment. This was actually an article that appeared in JAMA a year before 2 years before the Harvard Business Review article that I showed. Another great article that I would encourage you to review that talks about, this really is an institutional issue that needs to be addressed at the institutional level. So certainly becoming skilled in feedback, and not only giving feedback, but receiving feedback, role modeling how you take constructive feedback, helping our learners adapt to getting constructive feedback. In my new role as Senior Vice Chair for Faculty Development in the Department of Internal Medicine, I'm working on our annual reviews and the processes for it. And it's amazing how many faculty, and if I'm honest, I put myself in this category, expect themselves to be outstanding in every category, that there's no room for, oh, you're really very good. or you're exceeding expectations. No, I have to be outstanding or I'm upset. And so, role modeling how we as faculty accept feedback and have a growth mindset can be very powerful. Mentoring programs, cohort hires, or cohort recruits, meaning together and encouraging them to look towards each other for support. Certainly moving to holistic admissions, which our admissions committee is one of the leaders in the country in doing this, and it's remarkable, but taking some of that pressure off of you need to be a perfect applicant in order to come to medical school. Sponsoring help seeking and destigmatizing resources, which I know Dr. Sauer does in the Office of Professional Well-Being, and again, are being role models. And then this is the second very controversial idea that I want to promote. The first being, again, that imposter phenomenon and maladaptive perfectionism are overlapping or maybe the same concept, but in the context of systemic racism or discrimination. The second idea is good enough okay in medicine? The idea that excellence in medicine can be achieved by trying for good enough rather than perfection. The medical community, we have the sense that we owe it to our patients to be the best of the best, which is not the same thing as saying we owe it to our patients to be the best we can be. And so I'm not talking about slacking off or not paying attention to your patients or not being a great clinician. I'm talking about saying that good enough is the best one can do in any given situation to satisfy the requirements on hand. And the example the author uses in this article I cite is if you invite someone home for lunch, you need to provide food around noon. Serving simple sandwiches at lunchtime is good enough and better than attempting to serve a 10-course meal at 7 p.m. and calling it lunch, right? Given the givens of our schedules, it's nice just to have some sandwiches and it's appropriate. And the idea or concept of a good enough doctor or a good enough healthcare system has not gained popularity. And most of us do aim for perfection while struggling to balance personal and professional lives. And most healthcare systems try to provide patients with the latest and greatest in diagnostic and therapeutic intervention. And so in general, I think good enough means that what we're doing benefits our patients, absolutely. No critical problems, benefits outweigh any downside. And in the present situation, and all things considered, further improvement would be more harmful than helpful. That would be good enough. And I was thinking that during the pandemic, when we had all sorts of restraints on what we could and couldn't do for our patients, it's some level we accepted good enough, given that they're hospitals at 160% capacity and I'm treating patients in the waiting room. This is what I can do right now. But is there a way to carry that forward? And good enough has to do with rational choices, right? Not the 10-course meal for lunch, as opposed to compulsive behavior. So I want to come back to our case of Dr. X. And basically what you see with Dr. X is that as an early career, mid-career physician, she pushed herself too hard and she set herself very much in this cycle and was ready to leave practice after 20 years. For those of you who haven't figured it out yet, Dr. X is me. And for years, I have pushed myself too hard. And those of you who know me will say I still do. And I do, but I'm better than I was. And I'm really struggling with this concept of good enough. Is that the right concept we should be applying? Because I'll use myself as an example again. New Mexico needs primary care doctors. I feel I've done good work with learners and good work with my patients. And I would have hated to have had to leave practice 11 years ago. I feel I still have some good years in me, and I've had the past 11 years after a 6-month break. And I think a lot of people are pushing themselves so hard that they do burn out, they do feel undervalued, they don't recognize how much they're contributing, and leave medicine when we desperately need them. So in conclusion, I just want to say that imposter phenomenon, maladaptive professionalism are very common in our profession. They have serious negative consequences for individuals and for institutions. They may be the same, but in the context of the system. Again, that maladaptive perfectionism in a system that isn't as inclusive as we would like. We need to name and talk about these phenomenon, and we need to think about system level changes that are available. And in general, is being good enough in everything you do better than being outstanding in some areas and bad in others? And with that, thank you for your attention and the opportunity to be here. I'm going to stop sharing my screen if I can figure out how to do that. And really eager to hear your thoughts.
Thank you so much, Dr. Lawrence. Thank you for the amazing presentation and inspiration. There were not too many, there were a couple comments made during your talk, but no questions. Dr. Kreichman, though, just posed a question in the chat. I'm not sure if you can see it here about commenting on the deleterious effects of perfectionism on patient care.
I can see it. Thank you. And I think Dr. Kreichman named a number of the deleterious effects. You know, I think if I'm a perfectionist or really want to be seen by my patients as the best of the best, then I might be reluctant or feel very defensive if a patient seeks a second opinion. I might not be evaluating, I might not be responsive to a patient disagreeing with my treatment plan or saying, you know, this isn't the best. Or I might have a patient, I'll use a general medicine example, whose A1C is 7.5, and I think it has to be less than 7. You know, that's the target. That's where I have to be. That's my perfectionist side saying I have to meet all the guidelines, when really they're okay where they are and they're doing well and they're thriving in their life. And so can I be flexible and meet my patient where they are, as opposed to holding patients to a standard that may be unrealistic and has more to do with how I see myself than how the patient sees themselves. So thank you for that question. And I think you named all the deleterious consequences.
Thank you. All right, other questions?
It looks like, I don't know if that's Dr. Haynes but it looks like she has a question.
Wales. Yeah.
Wales.
I really appreciated the conversation about systems and culture and the fact of like, who are we bringing into medicine and what are we making them do to fit the medicine cookie cutter so that they can even be accepted into a program. A non-traditional learner myself, and it always surprised me, like the lack of flexibility and diversity within like success. What was the metric of success versus like what you actually need to talk to people and like continue to go to continue to work and succeed in this. So I very much valued that framing, because I've heard a discussion of this before that did not kind of consider those variables, and I believe this leads to greater questions and probably more systems change versus just like you do too much and you expect too much of yourself, do less, which is never a very useful way to go about helping someone change their behaviors or be more successful.
Thank you for those kind words. I do believe it's all about, or mostly about, the system. And, you know, just an example, we had Julie Jordan, who's Dr. Jordan, who's one of our physical therapists, give grand rounds in medicine recently about making the world more accommodating for all of our learners, right? I mean, that's part of the imposter syndrome too, is if someone feels like, oh, this classroom isn't accessible to me, this, you know, I can't read. Is there another way I can access this material or another way I can learn? We have to, you know, adapt to everyone so that they feel that they belong. Other questions or thoughts? Any thoughts on being a good enough physician?
Hey, Dr. Lawrence.
Yes.
I thank you for this. One question I had is, You focused on institutional responses to these problems, but it does sound like it's a national issue. So, one, what do institutions do to promote sort of national level change? And then two, what flexibility do institutions have to tweak the way that we do our training and education without running afoul of accreditation bodies like the ACGME?
Great question. And to some extent, our hands are tied by our accreditation bodies, but there is a lot of work going on at the national level to address some of these issues. So the AMA, the National Academy of Medicine, there's another private foundation, all for one in medicine. I think it's called the Lorna Breen Foundation, that is looking at these issues. And one example of something that's gotten a lot of national attention is how can we destigmatize mental health diagnoses? What can we do to change licensing requirements, change the wording of licensing requirements, take it out of licensing requirements, take it out of applications for credentialing, so that people don't feel like I can't get help because I'll have to report it and I'll be judged and I'll never get licensed again. So things like that are going on at the national level. The ACGME has a whole group of which Dr. Sauer is part, looking at well-being. They meet monthly and try to address these issues. They've looked at requirements. There's a panel working on things related, and I think this is a huge GME issue, but also a faculty and student issue, looking at parental leave. How can we expect, I had my first baby as a fourth year medical student, which was great in fourth year, but I forgot internship was coming. And then there was internship. And then I had my second one as a second year resident. And I had 6 weeks off in that second year residency before I was back on call. And, pumping in the restrooms at the VA. It just, and we've gotten better, but not that much better. So I think there's a lot of work looking at paternity and maternity and parental leave and bereavement leave. These issues are being looked at a larger level, but to some extent, you're right, our hands are tied. Dominique, and it's nice to see you. Oh, you're muted.
Hi, my name's Harrison Grace. I'm one of the new child.
I think Dr. Price was going to ask the question, but maybe she's
go
struggling.
ahead, sorry.
Please, Dr. Grace, go ahead. No, I think she's working on her technology.
Okay, I'll go slow for a moment in case she catches up. But yeah, I just wanted to share, I've had some, won't go too far into my background, like many of us, or all of us perhaps, long and twisty paths to where we got here, but I was in pediatrics prior, so saw some of those phenomenon that you alluded to there as well. But wanted to mention, as you talk about systemic things, I think one thing that really comes to mind for me is the way that, and this is an institutional and super institutional level, the whole institution of medicine talks about failure or the perception of failure or things perceivable as failure, judgment, I guess, in other words. One domain I've been seeing this and trying to work on it is in how like duty hour reporting works and how things like that get communicated to residents. What was originally, I believe, a program for the benefit of residents, to monitor that they were not overworking or that they had appropriate time and safe time between shifts. I think has over time, the decades, morphed into a kind of toxic thing of you need to log your hours maybe the right way, or maybe scribble them a little bit, if else you get a violation or are out of compliance. And really trying to change the language to it's more of the program or the institution is out of compliance, because that is what the actual kind of language is about. But yeah, just changing how we talk about things like that. So again, with that kind of internalized perfectionism, people don't feel the need to hide when they're struggling, suffering, or working extra. So the way we approach it. Yeah, totally.
Yeah, thank you. And I do think that to some extent, the institution or the system, which includes me, I'm owning my part of this, has a fixed mindset duty hours are violated. We're bad. We're going to lose accreditation, as opposed to duty hours are violated. How can we fix that and make it better? How can we change the system so that our residents don't have to work longer? And I think we all need to work on that growth mindset. Same thing with evaluations of supervisors. That's been one thing that's been really important in the wellness literature, is your direct supervisor seriously impacts how burned out you feel and how professionally fulfilled you feel. And those evaluations of direct supervisors are very intimidating if they're going to be met with punitive actions. But if they're met with coaching, it's a different experience. So really good point. And Dominique, are you back with us here?
I hope you can hear me.
I can.
It's good to see you too. You've worked with these with kind of students for so long. I'm curious, this maladaptive perfectionism, do you think we can reform, or is this sort of more of a almost like a personality disorder, and we attract these type of people into medicine? I'm curious to see if you've seen it. Can we reform?
Well, I think, I'll talk personally, my N of 1. I've gotten better over the decades and certainly started off as maladaptive as anyone else I know, and have gotten better through failure, through experiences of not doing well, of burning out. And so I think people can change. I think institutions can change. I think it's really, really hard to change a culture, and it's going to take all of us pulling in the same direction to do that. And so role models at every level changes how we admit people, changes maybe on metrics of how we evaluate people. Hey, I'm going to give you a great evaluation because you failed 6 times this year. Well done. I don't see that happening, but we have to really think about what it is that we call attention to and how we award people for that. I think it's possible. I know I'm over time. I'm happy to stay on if everyone else wants to run off, but it's been a pleasure, and I'm happy to carry on this conversation with anyone who wants to carry it on. Thank you, Dr. Sauer.
Thanks again so much for your time, Dr. Lawrence. And yeah, we can pause if others have questions or additional comments. Okay. All right. Thank you so much again for your time this afternoon and making this possible on relatively short notice. Thanks, Dr. Lawrence.
My pleasure. Thank you.
Take care.
Bye-bye.
Have a good weekend. Thanks, everyone.